Good day. For this lecture, we're going to talk about several topics. Okay, first is fibrinolysis. This is the means by which the blood vessels are kept clear of clots, and also this is responsible for the dissolution of the solid clots. In this process, plasminogen is converted to plasmin. Plasminogen is a substance produced in the liver. It is an enzyme, a glycoprotein found in the plasma. This is converted to plasmin by certain FACT activators. So these activators are intrinsic activators like 12A, factor 12A, kallikrein, and high molecular weight kininogen. Another one, letter B, is extrinsic activators. That includes TPA or tissue plasminogen activator and urokinase type plasminogen activator or UPA. Then letter C are exogenous activators that include therapeutic agents like, again, TPA from outside, streptokinase, and urokinase. So they are drugs or medicines that are administered to lyse existing clots. Plasmin. So this is a substance that should not be found in the circulation. Instead, what we should find is plasminogen, which is its precursor. It degrades. The action of plasmin is to degrade fibrin clots. So this will result in fibrinolysis and fibrinogenolysis, and also factors 5 and 8. This is also capable of activating the complement system. Certain substances are produced by the body in order to regulate coagulation and fibrinolysis. The first one here is antithrombin, which is from the liver. It is the main inhibitor of coagulation, and what it does is that it inhibits the different coagulation factors, the serine proteases. Therapeutic heparin can enhance the action of this substance, antithrombin. The next one is protein C and protein S. They are vitamin K dependent regulatory proteins. They are inhibitors, and they are activated when thrombin binds with thrombomodulin. It inhibits the factors factor 5 and factor 8 and provides a negative feedback on the cascade. The third one is tissue factor pathway inhibitor that inhibits the complex form between 7A, factor 7A, and tissue factor. Then alpha-2 macroglobulin, it inhibits thrombin, activated 10, factor 10, kallikrein, and plasmin. Letter E, alpha-1 antitrypsin, it inhibits activated 11 and inactivates plasmin. And then letter F, it also includes C1 inhibitor, so this is part of the complement cascade, so if you remember, and it also inhibits 12A, 11A, kallikrein, and plasmin. Next is alpha-2 antiplasmin, which is a principal inhibitor of fibrinolysis, and it acts by neutralizing plasmin. And then finally in the list is PAI1 or plasminogen activator inhibitor. It's also an inhibitor of fibrinolysis and prevents the activation of plasminogen by TPA. It is released by the endothelial cells when they are damaged. Thrombotic disorders. So if you remember, thrombosis is when there is the presence of blood clots in the circulation. This may be because of deficiencies in some regulatory proteins that we have mentioned earlier. Letter A is antithrombin deficiency. This is a genetic deficiency affecting about 1:2,000 in the general population, and the associated symptoms may be deep vein thrombosis and pulmonary embolism. So when the blood clots are deposited in those areas like the veins and the pulmonary circulation. This may be because of antithrombin deficiency. So because it is deficient, the enzymes are not inhibited, and there is an impaired negative feedback to the cascade process. So there is an activity assay, direct activity assay for this substance. Letter B, protein C or protein S deficiencies. So if you remember, they are dependent on vitamin K. They inactivate factors 5 and factor 8. They can cause, again, superficial and even deep vein thrombosis or pulmonary embolism. Just to explain, thrombosis means the presence of thrombus or blood clot in the circulation. So this one affects the vein, right, that are not palpable. So they are deep. Usually this is in the legs. And when we say pulmonary embolism, there is again a blood clot that is moving, okay, in the circulation. Okay, and then it may lodge itself. It may lodge itself onto the small blood vessels of the lungs. So that's why they say pulmonary embolism. Right. So laboratory, there are again immunologic tests that can be performed. Also functional testing for blood clotting testing that can be used for the measurement or detection of this deficiency. Another possible reason for thrombotic disorder is decreased activation of the fibrinolytic system. Certain clotting factors like factor 12, prekallikrein, and high molecular weight kininogen are important in secondary hemostasis, but it is also important in the activation of the fibrinolytic system. If there is a deficiency in these factors, this may be result in thrombosis and not hemorrhage. This is related to the genes, autosomal recessive genes. Factor 12, H-man factor, causes an increase in activated partial thromboplastin time and factor 12 assay. A deficiency in prekallikrein or Fletcher factor can also lead to a prolonged APTT, and aside from that, there may be shortening in the patient plasma that is incubated with kaolin. High molecular weight kininogen or Fitzgerald factor deficiency can also prolong the APTT slightly. Plasminogen deficiency is characterized by thrombosis due to the inability to generate plasmin. The third possible cause of the thrombotic disorders is genetic mutation. Letter A, factor V Leiden activated protein C resistance or APCR. This is the most common cause of thrombosis, genetically speaking. And this is because of a missing or substituted amino acid. Protein C is not capable of inactivating factor V Leiden, and it causes thrombin generation and formation of clots, fibrin clots. How can we detect this? There are molecular assays based on PCR, okay, single point mutation in the gene for factor V. Another possible mutation is prothrombin gene mutation 20210. The second most common hereditary cause of thrombosis, caused again by amino acid substitution, may have a slightly elevated prothrombin level. Again, there is an assay that can detect this mutation. Letter C, dysfibrinogenemia. This is an autosomal dominant trait wherein the structure of fibrinogen is abnormal, caused by genetic mutation. This may be associated with either bleeding or thrombosis and dependent on specific gene mutation. Secondary thrombotic disorders. When we say secondary disease or disorders, this means that this has nothing to do with the clotting factors. There are other reasons for thrombosis. Number one, lupus anticoagulant and anticardiolipin antibodies. These are autoantibodies that are produced against the platelet phospholipids for unknown reason. Number two, postoperative status. After surgery, thrombosis will be activated. Okay, and then number three, malignancy. Okay, there is an increased risk for malignancy because of thromboplastic substances by neoplastic cells. Number four, another possible source of secondary uh, thrombotic disorder is pregnancy. The placenta is rich in tissue factor and may enhance thrombosis during pregnancy. High-risk patients having cesarean operation are more prone to this. Factor 5 and factor 8 levels are increased, and this may trigger clot formation. Not only that, let me add that pregnant women are more prone to developing deep vein thrombosis, and this can be alleviated by using a kind of um, stockings. Number 5, estrogen. The use of estrogen and oral contraceptives can also increase the risk of venous thrombosis, even renal artery thrombosis. So caution should be given to women taking this kind of medications. Number 6, morbid obesity. When the person is too obese, it may result in antithrombin levels and PAI number -1, and it may lead to thrombosis. Hyperhomocystinemia, which is associated with atherosclerosis. If you remember, atherosclerosis is when cholesterol is deposited in the wall of the arteries, and it may result in arterial or venous thromboembolism. The mechanisms are not fully understood but may be associated with the reduction of and local activation of protein C. Aside from thrombotic disorders, we're also going to talk about hemorrhagic disorders or conditions that lead to bleeding. These can be inherited or acquired. Inherited disorders are those that may be related to the genes. For example, factor 8. If it is acquired, it may involve many components or pathways like warfarin therapy, heparin therapy, or liver disease. The symptoms that are associated with defects in secondary hemostasis are include bleeding in the deep tissues, the joints, the abdomen, and other body cavities. Letter D, inherited intrinsic pathway hemorrhagic disorders. Number 1 is von Willebrand's disease. This is an inherited trait, autosomal dominant, and this is the most common hereditary bleeding disorder. The abnormalities in both primary and secondary hemostasis. It is caused by a problem in the von Willebrand's factor, which is needed for platelet adhesion to collagen in primary hemostasis, and this is also a carrier for factor 8C in secondary hemostasis. Clinically, the person may experience mild to moderate bleeding because of the levels of von Willebrand's factor and factor 7. There may also be menorrhagia in women, that means painful menstruation. In the laboratory, we will find decreased levels of von Willebrand's factor and factor 8C. And there is one test which we call ristocetin test. There will be abnormal platelet aggregation. APTT is variable and bleeding time is prolonged. The treatment for this condition is usually by giving factor 8 concentrate and DDAVP, which is disamino-D-arginine vasopressin, which is a kind of antidiuretic hormone, artificial antidiuretic hormone. This is used to raise the plasma levels of the clotting factors, von Willebrand's factor, and factor 7LC. Another condition is factor 8 deficiency or hemophilia type A, classic hemophilia. This is transmitted from the X chromosome from mother to their son. This is the most common form of hemophilia, 80% of the cases, and the second most common hereditary bleeding disorder after von Willebrand's factor deficiency. There are new cases of hemophilia type A leading from spontaneous mutation. Bleeding symptoms depend on the degree of the deficiency, and spontaneous bleeding may happen and is especially bad in the joint regions, which we also call hemarthrosis. In the laboratory, we will see prolonged APTT and prolonged factor 8C assay. Treatment is by giving cryoprecipitate and factor 8 concentrate. In mild cases, DDAVP can also be used to stimulate the release of factor 8C and von Willebrand's factor from the reserves. 15 to 20% of the patients will develop factor 8 inhibitor, and this is associated with bleeding tendency and worse prognosis. Number 3, factor 9 deficiency or hemophilia type B, Christmas disease. This is a sex-linked recessive trait. Right, so it accounts for the other 20% of hemophilia, the third most common hereditary bleeding disorder. Clinically, again, there will be bleeding like those which is in hemophilia type A. There is prolonged APTT and factor 9 assay can be used to confirm this condition. What we give to the patient in the blood bank is fresh frozen plasma or factor 9 concentrate if available. Between 1 to 3% of the patient may develop an inhibitor against this clotting factor, and this can lead to further bleeding tendency or worse prognosis. Factor 11, hemophilia type C. So this is another deficiency. This is found in Ashkenazi Jews and characterized by clinical bleeding asymptomatic until surgery or trauma. Again, there is prolonged APTT only, so that means it's only affecting one side of the pathway. And factor 11 assay can be used to confirm this condition. Deficiencies of clotting factor 12, prekallikrein, and high molecular weight kininogen in the intrinsic pathway can lead to this condition. Inherited, extrinsic, and common pathway hemorrhagic disorders. Right, so let's talk about individual deficiencies of the clotting factors. Factor 7 or stable factor deficiency. This is autosomal recessive. Clinical manifestation is soft tissue bleeding and PT is prolonged. Factor 10 Stewart-Prower factor deficiency. Again, this is autosomal recessive. There may be soft tissue bleeding and chronic bruising. There may be prolonged PT and APTT, so that means it's affecting both the extrinsic and the intrinsic pathway, common pathway. Factor 5 or Oren's disease, label factor deficiency. Again, another autosomal recessive trait. There may be mild to moderate bleeding, prolonged PT, and APTT. Next, number 4 is factor 2 or prothrombin deficiency, autosomal recessive. There may be mild bleeding symptoms, prolonged PT and APTT. Factor 1 fibrinogen deficiency, another autosomal recessive trait. Okay, there may be a fibrogenemia, wherein there is lacking of fibrinogen in the blood, so it will lead to severe bleeding. Hypofibrinogenemia, when there is decreased in the amount of fibrinogen. Bleeding symptoms will depend on how much fibrinogen is lacking. Clinically, again, there may be bleeding of the following: mucosa, intestines, even intracranial sites. So this is dangerous. Prolonged bleeding time, okay, and platelet aggregation defects, decreased fibrinogen concentration, prolonged PT, APTT, and thrombin time. So those are the things that we can see in the laboratory. Number 6, factor 13 or fibrin stabilizing factor deficiency, autosomal recessive. So you can see that most of them are genetic. Clinical manifestations are spontaneous bleeding, delayed wound healing, and unusual scar formation. This is there is an increased incidence of spontaneous abortion in patients with this condition. Laboratory 5 molar urea test is abnormal. PT and APTT are normal. Enzymatic and immunologic studies can also be performed for this. Acquired disorders of coagulation and fibrinolysis. Right. So number 1 is hepatic disease. If we remember, most of the proteins in the blood are produced by the liver, except for immunoglobulins. Okay, among these proteins would be those that are classified as clotting factors or hemostatic proteins. Hepatic disease can result in decreased synthesis or production of these coagulation or regulatory proteins, and it will result in impaired clearance of activated hemostatic components. So what we will see is prolonged PT and APTT, even bleeding time. Platelets may also be decreased because of hypersplenism, alcohol toxicity, and DIC, disseminated intravascular coagulation. Number 2 is vitamin K deficiency. So we have been mentioning that this is necessary for the production of functional factors like factor 2, 7, 9, and 10. This is produced by the normal intestinal flora. This vitamin K, and deficiency in vitamin K may result in taking oral antibiotics. So if you take antibiotics, it may kill the intestinal flora. Vitamin K antagonists like warfarin, and decreased absorption because of obstructive jaundice. Breastfed babies are also prone to developing vitamin K deficiency because breast milk is sterile and there is no bacterial intestinal colonization that may occur. So prolonged PT because of deep clotting factors 7, 10, and 2, and prolonged APTT because of the involvement of 9, 10, and 2. Next, DIC with secondary fibrinolysis. The predisposing condition triggers systemic clotting, and it leads to systemic fibrinolysis and bleeding. What are these triggering events? The presence of septicemia with gram-negative organisms, acute promyelocytic leukemia, FABM3, obstetrical complications, so that means during obstetric procedures for pregnant women, massive tissue damage. The fibrinogen group factors 1, 5, 8, and 13 and platelets are consumed in the clotting process. What do we see in the laboratory? Again, prolonged PT, APTT, and thrombin time. The platelet counts, antithrombin, fibrinogen may be decreased. Fibrin and fibrinogen degradation products are present in the test, and schistocytes may be present, so leading to this condition would be RBC fragmentation because of clots, intravascular clots. A systemic thrombotic event can cause multiple organ failure, so this is a fatal condition. systemic lysis that ultimately leads to severe hemorrhage. Treatment is fresh frozen plasma and platelet transfusion, antithrombin concentrates, and heparin to stop systemic clotting. Primary fibrinogenolysis. Plasminogen is an inappropriately activated plasmin in the absence of a clot. Plasmin will circulate in the plasma and destroy certain clotting factors like clotting factor 1, 5, and 8. And this may be because of certain cancers like prostate cancer and massive tissue damage that can lead to release of plasminogen activators. Laboratory testing will reveal that PT, APTT, and thrombin are prolonged. The fibrinogen concentration is low. Platelets, RBC morphology, and antithrombin concentration are normal because there is no clot formation. Fibrinogen degradation products are present, so this is an abnormal FTP test, and fibrin degradation products are absent, so this is also normal. This is normal because of the D-dimer, because there is no clot formation. Clinical manifestation is hemorrhage that may resemble DIC, disseminated intravascular coagulation. Treatment is by using epsilon aminocaproic acid or IACA to turn off the inappropriate systemic lysis. Inhibitors to factor 8 and 10 are associated with bleeding. Little more. Sample collection, handling, and processing of specimens for coagulation testing. Letter A, non-traumatic venipuncture. It's essential that trauma must be avoided because if there is trauma, then the tissue factor may be activated. Order of draw. So this is when you are going to collect more than one tube of sample. So in this case, collect tube for coagulation testing before any other tube containing heparin and sodium fluoride or clot formation additives. The choice of anticoagulant for coagulation testing is citrate, sodium citrate, concentration of 3.8% or less. Use plastic or silicone coated glass tubes, and plain glass tubes will activate the intrinsic pathway and includes the activation of the contact factors, prekallikrein, 11 and 12 clotting factors. The ratio of blood to anticoagulant is 9:1. So make sure that you don't underfill the blood collection tube. If you underfill, it may lead to too much of the anticoagulant, and this is not going to be accurate. The testing will not be accurate. Okay, make sure to check the expiry date of the tube, the collecting tube, because expired collection tube may lead to underfilling. If you open the stopper, it may lead to overfilling. Right, anyway, specimen processing. Specimens must be processed as soon as possible and within 4 hours for APTT and 24 hours for PT. Centrifuge for platelet plasma to obtain and remove plasma from the cells. You can freeze plasma at negative 20 degrees Celsius. The temperature of the test must be performed at 37 degrees Celsius. Okay, and enzyme reactions work best at this temperature. Label factors 5 and 8 may break down at temperature higher than 37 degrees Celsius. Factors 7 and 11 may be activated at cold temperature. So that is why we are going to, as much as possible, keep the specimen at 37 degrees Celsius. So that is the last slide. Thank you for listening.